Good afternoon. We have with us Dr. Amit Dey, Senior Consultant Physician and Intensivist, Narayana Hospital, Jasori Road, Kolkata. Doctor, we welcome you to the Natco Pharma studio this afternoon. We look forward to hearing from you uh, about what you can tell the young generation doctors who are in the space of critical care and also those associated with bacterial resistance. How do you foresee the changes in critical care management?
Critical care management has been changed over last, ISCM, the governing body started at year of, I suspect this is 93. Then it was just clinical based. So after that, lots of studies, lots of evidence. So along with clinical knowledge and this evidence base, now critical care had reached that almost the peak. So this is the main change over last, say, 25, 30 years. Like sepsis management. So understanding of sepsis at 2001, then 2012, and at present has been changed, drastically changed. So as understanding changed, so management also changed. You got my point. See, another important thing is heart failure. Those patients admitting in case, apart from infection, heart failure patient, or is a good, big number of patients admitting with heart failure. Their management has been changed. So what we used to see and used to do, say 20, 25 years back, now the management of most of the diseases has been changed over last 25, 30 years.
Great.
My suggestion to my young colleagues, those upcoming consultant in critical care, so they have to stick to evidence-based guideline. This is definitely there. But they shouldn't forget to touch the patient. The bedside clinical knowledge is equally important for them. So unless they are blending these two, they will do misjudge to their patients.
You have in fact answered the very next question, and I like what you said is blending the bedside as well as
All evidence and
right.
guidelines.
What is the prevalence of carbapenems in
See,
your
in our
practice?
hospital, I have done last year 23 post-COVID, this era, because most of the patient that time was admitted in with COVID, because our hospital is COVID hospital. So no other than COVID patient, just 1 year, almost 1 year. No other than COVID patient used to get admitted. And most of them was ventilated. So the hospital-acquired infection, this HAP, what you call HAP or HAP, particularly among the ventilated patient, is 60 to 70% is somewhere between 63, 64. It was the carbapenem resistant. Most of the came is Klebsiella. Then comes E. coli and then Pseudomonas. These are three bugs over there. And Acinetobacter baumannii. The four usual bugs are there. Those are 60 to 70% they are the carbapenem resistance. And if you see this community acquired, particularly pneumonia, in UTI, these are around 30 to 40% are carbapenem resistant. So not only in the hospital setup, we are getting carbapenem resistance, a huge number. Also from the community, it is starting coming up, and that too a good number.
Right. What are the treatment options you would like to talk about in the carbapenem?
Carbapenem resistance, see, if patient is getting, ventilated patient count is going up, patient is uh, desaturating, so all other signs of infection is there. So straight away before getting culture report, I'm starting either colistin or along with colistin, or either colistin or one aminoglycan. Because in our setting, we are getting good number of patients who has aminoglycan sensitive. That is our backup calculation. Retrospective calculation.
So, Dr. Dey, we thank you for sharing your insight at the studio this afternoon, and we wish you all the best in your practice. Thank you for your valuable time.